If the USA system is so good, why would I say we're going to reform it, you might ask? Well, first of all, the public government plans, Medicare, which is for older people, Medicaid is generally for poor people, are unsustainable right now. Unsustainable and failing. The demographics of the United States, meaning the aging population and the risk factors, particularly but not exclusively from obesity, imply a disease burden that will literally overwhelm our system if the thing is not reformed, the system. And thirdly, and sort of hidden in the discussion, is that the Affordable Care Act caused serious problems, generated serious problems. It harmed patients with its regulations that caused higher insurance premiums, consolidation throughout the industry, and consolidation throughout the industry is generally accepted to be bad for patients. And it expanded government insurance that was substandard. And people patted themselves on the back and threw a party saying, look what we did, except they labeled people as insured with a system they would never accept for their own family. The bigger problem, and this is something I'm going to get into on how to proceed, is that the wrong incentives in the system are in place, both economic and health related. And the Affordable Care Act doubled down on that same pathway. They didn't invent that pathway, this law, but it's been there for decades, and it's the wrong way to have a healthcare system. There's another reality, and that is, although projections, as we see in climate change and other things, really never turn out to be accurate, the projections are that by 2050, there will be no money left for any federal expenditures other than health care and Social Security if nothing changes, based upon the traditional amount of money the government takes in. Zero money for any other domestic program, zero money for any international program. What happened specifically under the ACA? The ACA had two fundamental goals: increase the insured population and increase government authority over health care to reduce the costs of the system. These were the goals. And how did it do that? By adding essentially regulations, new mandates on businesses, new regulations on private insurance plans, new regulations impacting the payment of health care, and a significant number and volume of new taxes. It spent, in a 10-year projection, about $2 billion, half of which is on Medicaid expansion, and half of which is on supplementing private insurance. Did it reduce the number of uninsured? Yes, it did. We could see from the chart here that by the time things really, regulations came into play and had an impact, there was a significant reduction in the uninsured population. The problem is that 2/3 to 85% of the newly insured, depending upon what you read, under the ACA, the newly insured, were put into Medicaid. Now, why is that a problem? Problem number one, most doctors don't accept Medicaid patients. This was the status of things before the regulations really came into play, when 45% of doctors did not accept new Medicaid patients. And this is the situation in 2013. 54% of doctors do not accept new Medicaid patients. There's something even worse. This is HHS data I dug out. The percent of doctors and hospitals who had contracts signed that they accept new Medicaid patients, half of them did not accept new Medicaid patients. You're labeling people as insured, and that's all it is, a label. Second big problem is that Medicaid patients have worse health outcomes than people with private insurance, and at times worse than patients with no insurance at all. Now, why do I say that? Well, because I looked at the data in the medical literature. Peer-reviewed data in the best journals in the world, Annals of Surgery, Cancer, American Journal of Cardiology. These are controlled studies. It's not because those patients were sicker. These are controlled studies for everything in a comparison. And we see they had longer hospital care, more deaths, more recurrences, more strokes, more heart attacks post-op. They die sooner. People say that can't be. Well, these are the papers, in case you wanted to look them up. How could it be that they even possibly have worse outcomes than people with no insurance? Because when you enter a hospital with insurance, that determines what's available to you. In the United States, when you enter with no insurance, you get a full court press, ironically. What about health care expenditures under the Affordable Care Act? Well, it was touted in this article in 2013 by David Cutler, who was one of the main advisors on the formation of the Affordable Care Act, that the health care law's success story was slowing down medical costs. And it is true that this is the curve of U.S. health spending over time, and we see that it's plateauing or even decreasing. By the way, this is government speak for reducing, but it's really reducing the rate of increase. This is how the government talks. When you compare that and you say, wow, that's pretty good, it must have worked. Except you look at the other countries all over the world in the OECD, and every one of them has the same curve. Unless they somehow magically implemented Obamacare in their country, you have to question the validity of the conclusion, and the conclusion actually is this from the OECD itself, that since the 2008 financial crisis, the health spending has slowed in almost every country because of the financial crisis. Does that really make sense? Well, yes, it does. When you look at the United States alone, after every recession, there's a decrease in health spending. And once the recession ends and the economy recovers, health spending increases, and that's what we're seeing. Well, what about this idea of, well, we tried, the ACA supporters say, we tried the private model. We did what the Republicans wanted. We put a private insurance exchange up. This is a quote-unquote Republican idea. We put a marketplace forward, giving people choices. Well, what happened? Because we know it worked in private companies that banded together and put up insurance exchanges, that health insurance choices went up and people opted for cheaper insurance, things went down, et cetera. But somehow in the Affordable Care Act, premiums went higher. And they went higher because of the fine print of the regulations. Not to mention that it costs a massive amount of money in subsidies. Well, here's the numbers. Private insurance, since the Affordable Care Act went into play, and all the regulations were present, this is the premiums for individuals and families, the increase, yet the deductibles also went higher. Deductibles on insurance are the amount you pay before the insurance comes into play. So usually if the deductibles are higher, you're paying out of pocket up until a certain point, the insurance should be cheaper. It actually, everything got worse. It cost more money and your deductibles were higher. There's a second problem. Besides these regulations that cause that, there's another reason that happened, and that is that there's a cost shift to people who had private insurance. Because from this graph, we can see that historically this has been true. Medicare and Medicaid pay less than private insurance for care. But that really isn't the point of the graph. The point of the graph is Medicare and Medicaid pay below the cost of delivering the care. That's the key fact here. This is till 2012. And we see that this is the average, this line represents the underpayment versus cost. We look at this, look at the underpayment once the regulations went into effect. This difference, many people think, was shifted to people with private insurance, and this is the amount that has been calculated for that shift. This is pre-Obamacare, the amount, when the numbers were way down here. that a family of 4 paid over $1,500 a year extra in health insurance premiums because of the underpayment by government insurance, and even more than that if you count all the copays. And that number, of course, explodes when it becomes double. Access to doctors and hospitals in private insurance was reduced under the Obamacare law. Plans went from sort of broad coverage to narrow. This is narrow in terms of the networks that accepted patients with that insurance. Here's one sort of stunning example. You think, oh, wow, we have the best cancer hospitals in the world here. I have cancer, I'm going to go to MD Anderson, Sloan Kettering, Stanford. Well, no, those places, you may have insurance, but they don't accept that insurance under the Obamacare exchanges. So insurance, you've got to read the fine print here. In addition, the doctor networks, specific types of doctors were restricted, newly restricted in Obamacare private insurance. Fewer oncologists, fewer cardiologists, psychiatrists, even primary care. The choice of insurance plans, this is per county, dramatically reduced. Once the regulations were in place, there's a massive jump because insurers withdrew from this regulatory environment, and so you didn't even have a choice of what kind of insurance to buy. What should happen now? Now here's the, I feel, most important concept in understanding healthcare reform, and sort of the most misunderstood, unfortunately, by the people writing the laws for healthcare reform. Congress focuses on making health insurance more affordable. Whether they're on the Republican side or the Democrat side, Obamacare gave subsidies for insurance. Republicans often have said we should give these so-called refundable tax credits. It's basically money to people to buy insurance. And the problem is that insurance is really not the primary problem. The insurance is a reflection of the cost of medical care mainly. Traditionally, the cost of the regulations to the policy premiums has been small, although Obamacare sort of changed that with its heavy regulations. But the key here is, this is what happened with the increase in premiums under the Affordable Care Act. It was almost all due to the regulatory environment. It wasn't that somehow the price of medical care exploded. Here's the issue. The goal should be to reduce the cost of medical care. Once you reduce the prices of medical care, insurance becomes obviously much cheaper, as do the expenses on government programs and everything else, and access broadens. So the question is, how do you do that? How do you reduce the price of medical care? Well, first, we incentivize and equip consumers to consider price. This is the only good or service in the United States that people buy without even asking what it costs. They have no idea what it costs. Why? Because they don't care. There's this idea, because of the construct of insurance, that, quote, someone else is paying. If you're not paying, you don't care what it costs. Why would you care? So we need to change that with changing the structure of insurance and giving people vehicles to save money and benefit from that saving if they don't spend it on health care. Is it even feasible to shop for medical care? The common statement is, how can I shop for medical care? I'm having crushing chest pain in the back of an ambulance. Well, only 6% of medical care is emergency. 40 to 60% of medical care is for scheduled outpatient care in the United States, even for the people who are in the top 1% of spenders, who spend almost $100,000 a year on medical care. Scheduled non-emergency care is possible to consider value and price. Does it work? Yes, it does. We know it does because it's been done in various subpopulations. Almost a 20% reduction in price for things like outpatient MRI scanning or outpatient surgery when people care and the prices are visible. And the two vehicles are high deductible, limited mandate insurance, which means you pay more out of pocket, and very large, liberalized use, valuable health savings accounts, including for seniors who are the biggest users of healthcare. We want everybody in this game of caring about what it costs to leverage the prices lower. Second big point, increase the supply of medical care and stimulate competition for patients' money, just like it is in every other good or service. How do I do that? Well, we know there's a projected doctor shortage. We've been known that, and this has been known for decades. Not just primary care, but mainly specialists and surgeons. We need to do something about that. Increase the number of doctors. There are obstacles in place put in by the medical profession to limit the flow of doctors, the production of doctors. In addition, there's a tremendous battle of doctors to prevent equally capable people from giving simple primary care, nurse practitioners and physician assistants, that give care with the same outcome at about half the price, really, is what the data shows. And reform the tax code to eliminate what are counterproductive incentives. I'm going to skip through that and go on. The principles of the Trump administration healthcare reform are similar to what I've outlined here. Deregulation, consumer empowerment, making people care about what it costs, and then giving them control of the money, improving price transparency, and adding competition to the equation. And so far, without going into detail, and I'm happy to answer questions about this, there's been some positive results.